So moving on to our manual testing bench, on this bench we perform our granular fever screens, malaria and sickle cell tests. So with the malaria, we use the one-step malaria antigen kit, which has a built-in quality control. And this test is a immunochromatographic assay. So as the test sample flows through the membrane assembly, after the addition of the clearing buffer, which is in the little bottle there, the coloured colloidal gold conjugates of monoclonal anti-P falciparum and monoclonal anti-pan complexes in the lye sample. The complex moves further onto the membrane to the test region, where it is immobilised by the monoclonal P falciparum and the anti-pan specific antibody coated on the membrane. So this leads to a formation of the pinky purple coloured band, which you can see there at the top. It's the red colour band on the control. If it was positive, there would be a pinky purpley coloured band next to the P falciparum or the pan sign, but with the absence of these coloured bands in the test region indicates a negative result. So as you can see, this result is negative. So with every malaria test, we also make a thick and a thin blood film, as this is the gold standard for detecting malaria. And these are stained with Giemsa. These ones aren't currently stained at the moment. They're waiting to be stained. So the thick films are used for quick malaria parasite detection, whereas the thin films are used for species identification and parasitemias. And we do participate in an EQA scheme for malaria, and this is also through NEQAS. So moving on to glandular fevers, we use a kit called Clearview IM. So those patients who've been infected by the Epstein-Barr virus, they may develop heterophile antibodies, which are able to react with red cells of different species. So this test is a chromatographic immunoassay, and the sample is drawn along the test strip and encounters the bovine antigen bound to the strip. So if the antibody is present within the sample, a reaction takes place, resulting in a red line forming on the test strip, which you can see there. So as the sample continues to draw along the strip, it next encounters the control line. In the same way, the red line forms to indicate that the test has worked correctly, and with each batch of IMs that we run, we do a positive and a negative control, as you can see down there. So the positive control contains the heterophile antibodies, whereas the negative control does not. If we get an equivocal result, we do suggest that the test is repeated, probably within the next 7 to 10 days, as maybe the patient hasn't yet developed a high enough titer of antibodies to be detected as a full positive result. So moving on to the sickle cell, this solubility test is used as a rapid screening test to detect hemoglobin S. So the test is based on the principle that deoxy-HbS is less soluble in a concentrated phosphate buffers than all other hemoglobins. So this results in a turbid solution, so when placed in front of the reading block, if you can see the positive result there, the lines are not visible, whereas a sample that does not contain HbS remains transparent and the lines are visible. So you can see that one in the middle that's negative is visible. So this obviously indicates a positive result for HbS or a negative for HbS. All of our positive results, they get referred to our Sheffield Hospital for high performance liquid chromatography, and that allows them to distinguish whether the patient is a sickle carrier or has sickle cell disease. So for each test, as you can see, we perform a positive and negative control, and we are also involved in an AQA scheme through NAQAS for different hemoglobinopathy variants. Okay, so moving on to coagulation, we'll just go back around. So these are our coagulation analyzers, and we use the green top sodium citrate samples, which you can see there. So the sodium citrate anticoagulant reversibly collates the calcium ions within the sample. So when calcium ions are added, it allows the clotting to be induced. So firstly, the samples are centrifuged to separate the red cells and plasma, and then they are placed on our CS5100s. And as you can see, these analyzers have an open access at the front to load the samples on. All the reagents and control material is kept on board, as well as the cuvettes that are kept in this little side department here. Okay, so obviously the sample is loaded onto the analyzer, and it's loaded into one of the cuvettes that's stored on the analyzer, and light is passed through it, which is detected by an optical light detector. So one of the main tests in which we perform on these analyzers is prothrombin time, also known as PT, and this measures the extrinsic pathway, so factor 7, as well as the common pathway, which is factor 10, 5 and 2. So the test works by reacting the patient sample with a reagent called Innovin, and this contains tissue factor to activate the extrinsic pathway, and then calcium ions are added to induce the clotting. So as the clot begins to form, fibrinogen is converted to fibrin strands, which absorbs the light passed through the cuvettes, so less light is detected, and then this is plotted on the y-axis. And then a clotting curve is plotted to give the PT in seconds. So we'll also report the PT as an INR, which is International Normalised Ratio, and this is mostly used for warfarin dosing. So most labs use different thromboplastin reagents, so these should be calibrated to an in-house standard or an international standardised index, and then that's calculated for the INR. So it's calculated by the patient's PT divided by the mean TP from the normal patients, then multiplied by the power of the ISI value. So the patient's INR should be the same at every hospital, and this allows them to be warfarin dosed at other hospitals, as the results should be the same. So another test we perform on the analyzer is a APTT, which is an activated partial thromboplastin time, and this measures the intrinsic pathway, so factors 12, 11, 9 and 8, as well as the common pathway 10, 5 and 2. So the test works by using Actin-FS reagent, which acts as a contact activator, which then obviously activates the intrinsic pathway. So the sample is introduced to Actin-FS reagent and incubated for 3 minutes at 37 degrees. And this only allows the cascade to progress as far as activated factor 11, after which the calcium ions are added to allow the cascade to follow through to completion and for the clot to form. So the test is measured in the same way as a change in optical density, and the clotting curve is plotted with the first derivative, but then the second derivative is plotted, which is the steepest point of the first derivative. Then the highest peak of this is used to give the APTT in seconds. So patients who are receiving anticoagulants such as heparin, they may have a prolonged APTT, or patients who are on warfarin, which is a vitamin K antagonist and affects factors 2, 7, 9 and 10, they may have a prolonged PT. So in any cases where the APT is prolonged and we know that the patient is not on any anticoagulants, so if the APT is greater than say 40 seconds with a normal PT and they're not bleeding, we would then go on to perform an APTT 50-50 mix. So this is a new test that we've just started to do in-house. We did used to send these off, but at the moment we are busy validating our machines to perform this ourselves. So by doing this mix, it's used to detect whether the prolonged results are due to a factor deficiency, an inhibitor, or maybe heparin contamination. So the other test we perform due to the high APTT is a thrombin time, and this is to detect whether a prolonged APTT is due to heparin contamination. So the patient may actually be taking heparin anticoagulant, or it may be IV contamination if the sample has been collected from a heparinized line. So this can detect contamination, as the thrombin reagent used is actually sensitive to heparin, so it will cause the thrombin time to be prolonged. So the test works as the thrombin reagent provides an excess of thrombin, which allows the fibrinogen to be converted into fibrin, and then obviously that bypasses all the coagulation factors in the cascade before this stage. Then the results are compared to a standard curve, which are plotted on sample containing no fibrinogen levels. So by comparing the results against a standard curve, it can be used to give a thrombin time in seconds. Yeah, I think that makes sense, sorry. Other tests we perform in-house is the D-dimer. So D-dimer is the breakdown product from the clot, or the fibrin or fibrinogen degradation product. So this test is requested for patients with suspected venous thromboembolism, pulmonary embolisms, deep vein thrombosis, or in DIC when small clots are formed and are also broken down. So the D-dimer test is an immunoturbometric assay, and it uses monoclonal antibody-coated latex particles that react with the D-dimer. The reagent is called an Innovent's D-dimer assay. So when D-dimer is present, aggregation occurs, and the turbidity of the plasma increases when obviously the light scatters. So the amount of scattered light is proportional to the amount of D-dimer that is present in the sample. So in cases where the result is 0.5 or greater, that indicates a positive result. So the patient should be sent for an X-ray or an ultrasound scan, and that's to detect whether there is a clot present in the body. So the final test we perform in-house is anti-10A, and this is performed for low molecular weight heparin. So for example, this could be deltaparin. Normally these patients don't need monitoring because obviously low molecular weight heparin produces a predictable response, but we may perform an anti-10A for patients who maybe got renal failure or low body mass, such as children, and the reason for that is because they're unable to actually clear the low molecular weight heparin as quickly as normal. So the test works using a chromogenic assay, and the patient's sample containing the low molecular weight heparin is mixed with a fixed amount of antithrombin. The complex which is formed is then able to neutralise factor 10A, and any residual factor 10A which remains is then able to cleave pyronitrile aniline, and this produces a colour change which is measured spectrophotometrically. So the amount of colour change is inversely proportional to the amount of low molecular weight heparin which is present. So anti-10A tests can also be used on patients who are on direct oral anticoagulants. So this could be rivaroxaban or apixaban. But at the moment we still send these tests away to Sheffield. So maintenance is performed on these analyzers every night. We're doing an enhanced probe clean, and we'll check all the reagents are topped up as well as the cuvettes, and then we QC all of the tests. So the QC is also ran at 2 p.m. Every day, and if any reagents are changed throughout the day, QC is also ran after this change. We'll also participate in EQA schemes for all the tests we perform on our CS analyzers, and this is also through NEQAS. So the final department is morphology. So this is our morphology room. So band 5, 6 and 7s all review blood films each day in this film room, and any films that need second checked are referred to our consultant haematologists. So urgent films that need urgently reviewed are popped up here, and each day they come down and they check these films that have been put aside to them. We'll also participate in EQA for morphology, and this is done through our NEQAS scheme. So this scheme provides they provide us blood films for us to review, and then we can report on any morphological abnormalities we detect, and we'll also have to try and see what basically the initial diagnosis is of the slide that's been provided. But this is submitted as a lab consensus, not as an individual result. So after the scheme, a report is provided with what morphological features should have been detected, as well as an expert comment about the condition and what features that you should expect from that condition. We'll also participate in digital morphology. So slide is provided to us online electronically to review, and again we report on any morphological abnormalities detected and do an initial diagnosis. But this scheme is obviously an individual participation submission rather than a lab consensus. So every member of staff should participate in the EQA scheme as part of their morphology competency. But we do also complete in-house morphology competencies as well. And this just helps to show that you can identify things such as malaria parasites, platelet clumping, blasts, polychromasia, fragments. So more specialised features that you may not see on everyday normal blood film. So there's also some film training sessions which are led by our haematology consultants. So they pick out any interesting films from their patients, and then we would review them together using this computer screen up at the top that we can bring the film up on. And obviously then we can use this towards CPD and extra training and things like that. So that is the end of my specialist tour. I hope I made sense, and thank you for watching.